you so much to JDRF for providing these opportunities for all of us. I thought because it was a small group, it might be nice to just sort of sit and have this be very interactive because I really want to go in the direction that you feel would be most supportive to you. First of all, I'd like to tell you how I got involved in JDRF. And then I thought if you're comfortable, you might introduce yourself and say what your connection is to diabetes, who your loved one is. This is being filmed, so if anybody's not comfortable being on camera, certainly let us know, or if you feel that you don't want to identify yourself, that's perfectly fine. Is anybody uncomfortable with that? No? Yes, yeah. Do we look nice? How's the hair? Everybody looks beautiful.
Feel free what purpose, Ginny. What are you going to use it for?
So I got involved with JDRF when my oldest of my 3 children was diagnosed with type 1 when he was a preschooler. And he is graduated from college now. So I can tell you that these children can lead wonderful, active lives, and not anything needs to get in their way. Nothing physical. There's nothing that needs to get in their way. And I remember meeting a lovely teenage girl who had been diagnosed several years before my son was diagnosed in the hospital. And that was such a comfort to me to know that nothing had to stand in their way. And I've been involved with JDRF ever since. So would you like to introduce yourselves and say what your connection is? Should we start here?
Surely. My name is Kathy Power. I live in Brookline, and I have I have 7 grandchildren. I have 2 that have juvenile diabetes. One grandchild was diagnosed at 4, and she is now 13. And now on another totally different side of the family, because now my son and daughter-in-law, their twin boy just was diagnosed at 16 months. He's going to be 2 on Saturday.
Wow, very, very young. And you may know, or I don't know if you know, but that's the largest increase in an age segment is those under the age of 3. That's the most rapidly increasing age of diagnosis is under age 3. And you?
I'm Blaine Walsh. I live in Needham, and our grandson, Timmy, was diagnosed at the age of 2. He will be 12 on Saturday.
Wow. Wonderful that you're coming to these things having had so much experience. So you're not just new to this, and you can offer support to families that do have new diagnoses. So it'll be really wonderful to get your feedback as well.
My name is Cheryl Brommy. I also live in Brookline. My 5-year-old grandson was diagnosed in January of this year. He's a kindergartner in public schools. And I also have a sister who was diagnosed in her early 20s in 1981. Is all grown up. A great source of inspiration for Noah, my grandson.
Great, great. So these are early days for you with your grandchild. Yes, yes.
I'm Judy Myers. I'm from the North Shore, and my granddaughter Carly is 13, and she was diagnosed Christmas when she was in kindergarten.
Okay. Okay.
And it's been a process, but she's really good. She went through a little phase where she didn't want to do this anymore for about a day or 2, and her mother got right on her, and she's fine with it now. But she's great. They just see the world a little bit differently, a little bit deeply, and wonderful. Things don't bother her as much as I think her sister.
And we still continue to learn, don't we?
Yes.
We still continue to learn, even though you've been living with this for quite some time, and so do those of us in the profession, because we continue to learn from our families, and things are ever evolving with the research as well. So it's wonderful to have these opportunities to share.
Hi, I'm Nancy Donahue. I live in Watertown, and my grandson Brady was diagnosed on March 12th. He lives in Florida.
Okay.
We're going to see him in June for a couple of weeks.
So trying to prepare for that visit and get some level of comfort. Yes.
The more I read, the more I get confused.
And overwhelmed.
Okay,
Overwhelmed. Yeah, that's a completely normal feeling.
How old is he, did you say?
He's 5. He'll be 6 in June. Seems to be okay with it. I know it's a lot of work and numbers and went through a little stage, he was angry, and my daughter said, "That's okay. I'm mad too. You can be mad."
Right.
And then,
Right.
but here you go, and this is what you have to do. And
Yeah.
He does it.
Very healthy. Yeah, very healthy.
I'm Kevin Downey, Macy's husband. We've bought, the volumes of books already, and we're just getting overwhelmed, and so I'm glad to be able to listen to some of your stories and to kind of get the info firsthand. And at this point, he can probably teach me. I know he's pricking his own finger, so he could probably teach me what to do.
Right.
But he's going to be in our care for a couple of weeks without Mom around, so we sort of need to know how to do all this.
Yes. Yeah. Exactly.
It does get better.
Yeah.
It really does. It's never great, but it does get better. Zach was diagnosed at the age of 3, and he's 7.5. And I remember those early days. I mean, we were afraid to move. We didn't know what to do first and how to calculate all the things we needed to calculate. But he's great now. He's on a pod.
Which is a type of insulin pump.
Which is a type of pump. And he tests himself, and we oversee it because he's only 7. But he's really doing everything that all of his friends are doing.
Great. And do you interact with your grandson regularly?
Yes.
You do? Okay, great, great. Well, Lauren has put together a wonderful packet for us. And some of these things I'll let you go over at your leisure at home. There is a wonderful article here that I will have you read on your own when you get home. And it's about grandparents. And it's about how you can be supportive. And it's titled Grandparents No Greater Reward. And I have to say that's absolutely true. The fact that you guys are here and supporting your families is absolutely enormous. Because diabetes really is a family affair. And our children that are well supported do very well. They go on to become very accomplished adults. It's a tremendous challenge managing diabetes because there's so many day-to-day tasks. But these children that do that well go on to become very accomplished because they develop a discipline at a tender age that some people never develop, even adults. So with a lot of support and encouragement, not that there won't be rough bumps, these children can really go on to do really wonderful things. Now it sounds like from talking to the group that we have from little ones up through teens, right? Is that what I got from that? Okay. So there's going to be a variety of things that we can discuss. And some of the things that we've chosen to review are the differences between type 1 and type 2 diabetes. Although everybody here, their grandchild has type 1, is that right? Most of us, however, have some type 2 diabetes in the family as well. Is that true for people in this group? Is there no type 2 in the family? That's very unusual. That's very unusual because the incidence of type 2 diabetes is increasing enormously in our country and around the world. But I will just review briefly the differences. Type 1 diabetes is an autoimmune condition, and that means that the body mistakes the insulin-producing cells as an invader and actually kills those cells, destroys those cells, so that eventually children are completely insulin dependent because their pancreas no longer makes insulin. With type 2 diabetes, there's a much stronger genetic link with type 2 diabetes. With type 1 diabetes, only 75% of us with type 1 in the family don't have any family history, so the vast majority. But with type 2, there's a much stronger genetic component. It is more related to sedentary behavior and obesity, but certain body shapes are more insulin resistant and are prone to type 2 diabetes. But with type 2 diabetes, you still produce insulin. You're just extremely insulin resistant. So that can initially be treated with diet and exercise. It can be confusing for people with type 1, especially with children, because families will often hear, oh, do you feed them sweets? Or do they not exercise? Or do they have to be on insulin their whole life? People really don't understand the difference. So it's very important for you to understand that with type 1 diabetes, that it is insulin dependent for that reason. Some of the other things that we have some articles in here on are just sort of an overview of blood glucose monitoring and how important that is, to tell you what the blood sugar is, especially if the blood sugar is low, because that is a medical emergency. And we can talk about that, especially if you have concerns about that, and I'm sure you certainly do. The other thing that we can talk about is the different types of insulin regimens, injections, insulin pumps, things like that. Things are very, very sophisticated in this day and age, and there's a variety of regimens. I know you have a grandchild on an insulin pump. Anybody else have children on insulin pumps? Mm-hmm. So as you can see, a lot of children are on insulin pumps. At Children's Hospital, we have about 1,500 children with type 1 diabetes, and probably 40 to 50% of our children are on pumps. So the majority still is not on pumps, but you can see it is a popular option. How about those with children on an injectable regimen? Do you know the names of the insulin that they're on, or not familiar?
Can you give us, are there only a few?
Well, there are a few. Are they on a multiple daily injection routine? 4 shots a day? So probably Lantus insulin and then Humalog whenever he eats?
Yeah.
Does that sound right? Yeah? Yep, pretty much that's what the majority are on now. But there is NPH insulin, which is an intermediate acting insulin, and sometimes you can mix that with a rapid acting insulin to cover lunch. And then in that scenario, you might only be on 3 shots a day. So it's a lot of shots. It's a lot of shots, and there's a lot that you have to take into account in terms of determining that insulin dose. And one of the most important things is to be very conversant with carbohydrate counting. And everybody's nodding, everybody's shaking their head. So you become very good eventually, actually fairly quickly, at knowing what the carb content is of everything in your cabinet. And that will be a very important thing. And the diabetes team will give you ranges of carbohydrate targets for meals and snacks based on age and energy expenditure and things like that. But with a lot of the insulin regimens out there now, because you're given a insulin to carbohydrate ratio, does that sound familiar? Okay, so an insulin to carbohydrate ratio is how much insulin or how many carbohydrates does each unit of insulin cover. And every child is different based on their age and their size. And that's how you dose the insulin. So if they say...
Our ratio has been changing sometimes daily.
Constantly. Daily's unusual, but...
We had a little, apparently we've just gotten over our honeymoon.
Yes.
So
Yes. So the honeymoon phase of diabetes, for those that are not familiar with that term, is when children are first diagnosed, oftentimes there are still some remaining beta cells. The beta cells are the cells in the pancreas that produce insulin. And they think that about 80% of those have to be gone before children start to become symptomatic. The remaining 20% just can't keep up. So that's when the polyuria, which means frequent urination, polydipsia, which is the thirst, and the increased hunger begin. Once we give children some insulin, those remaining islet cells, because they've gotten reinforcements, can start producing insulin. And so when that happens, the blood sugars are really pretty stable. They're on very, very small doses of insulin. But the autoimmune process continues to march forward, and as that happens, the insulin dose is going to go up. The outside, the insulin that we're giving these children is going to go up. Plus, they're always growing and gaining weight. So that's the challenge of managing diabetes in children, is that it's very dynamic. It's never static. When they reach adulthood, or even late teens, and that huge growth spurt stops and the growth hormone is no longer antagonizing the insulin, then they level off. But it can be quite a bumpy ride during adolescence. And a couple of these articles refer to that, and that's a good thing for you to read, because oftentimes children and families personalize that or take that on when that's just a sort of a normal challenge of that age. And how about insulin administration? We've got some pumps, we have syringes, I'm imagining, right? And how about insulin pens? Is anybody using any insulin pens? No? Okay. Insulin pens are another lovely way of administering insulin. It's a little bit more discreet. They really do look like a pen, and you just screw on a little pen needle, and especially if you're going out to a restaurant or something, it's a lot easier than doing one of these with a vial. And that's up to the the diabetes team and the families to determine whether they want to use those. But and nobody's mixing insulin, correct? Nobody's mixing insulin? Okay, okay. And that's because it sounds like everybody's on a basal bolus regimen. Have you heard that term? Has anybody heard that term? Okay. So these are really good, these are good things to review. 50% of the insulin that our body needs is basal or background insulin. The other 50% is to cover the food we eat and to correct for high blood sugar. So with an insulin pump, we program that pump to give basal insulin steadily throughout the day, depending on the child's individual basal need. If you're on an injectable regimen, which mimics an insulin pump, you give Lantus insulin once a day, that's the basal insulin, and then you give bolus insulin or Humalog or Novolog insulin whenever the child eats. So you can have a basal bolus regimen whether it's injectable or whether it's via an insulin pump.
So in the pump, because we're
moving in that direction?
To a pump,
Yes.
They are going to pump class and
Yes.
everybody's wearing
Yes.
pumps. He'll still be getting essentially multiple injections. Is that, I mean, it won't be injected, but the pump will deliver insulin in the same fashion that we do now with a
Well,
syringe?
the nice thing about an insulin pump, we were talking about multiple daily injections. So if the child eats 3 meals and 3 snacks and they're out of the honeymoon phase, during the honeymoon phase, sometimes you can get away with not covering those snacks with insulin. But once you're out of honeymoon, you've got to inject every time you eat. So 3 meals, 3 snacks, that's 6 shots plus Lantus, that's 7 shots. That's a lot of shots. With an insulin pump, you change the infusion catheter every 2 days. So that's 1 shot in 2 days as opposed to 14. And putting the infusion catheter in is very similar to an injection. It doesn't hurt a whole lot more. Needle's a little bit bigger, but most kids feel like that's a really good deal, to do a catheter change every 2 days as opposed to multiple daily injections. So then you program the pump to administer this basal insulin. The Lantus goes away. Okay, so in an insulin pump, you're only using the rapid-acting insulin, which is Humalog or Novolog, and then you program the pump to deliver basal insulin every hour. And that's determined by the child's insulin need, and that's calculated by your diabetes team. Insulin pumps are pretty sophisticated. They cost about $6,000. They're very mainstream. Insurance pretty much covers them, and there's a wide variety of them out there. That's why we have families attend pump class so that they can be exposed to that. And then we usually have our children wear a catheter or a pod filled with saline for some time to see if they're comfortable with it. We like them to play sports with it and to figure out what's the best fit for them. Does anybody have any questions about insulin administration? Okay. How about some of your questions? Why don't we, I'm wondering if we should answer some of your specific concerns, because we do have some handouts here on how to identify a low blood sugar and how to treat that, or identify a high blood sugar or treat that.
I was out shopping with my granddaughter, and she's 13, and she said, I'm feeling low. So she's familiar with what's going on. I instantly panicked. Thought
Right.
first thing, where's the nurse? Okay. What do I do if she just faints on me? That type
Right.
of thing. But I didn't.
Right.
But we did get her out of there. But she was very comfortable with it when we were checking out. She was looking at different things. But we bought her something she wanted to bring her sugar up.
Okay.
And it only took a minute before she said, I'm feeling better. But it did make me nervous.
Yes.
Did you check her though when she said she was feeling low?
She checks herself.
Oh,
And
so-
because she was feeling low, she just ate the candy
Oh,
until she felt better. And then she checks herself after that.
Because we check, when he says he's feeling low,
What do you do?
we check him, or have him check himself.
Right.
And usually he's right, and then we give him whatever jelly beans, glucose tabs, whatever I happen to have on me. And
Mhm.
we always have something.
Right.
Never go out without
And
it.
that was a time I did not have anything with me. I'm just so used to her.
See, that's
having
why
it.
she went
That's
well.
right.
She does
That's
carry
right.
she does carry these little sugar.
Yes, glucose tabs.
In with her,
Mhm.
her case that she carries around.
Right.
She has with her constantly. But that pump is great.
She's on a pump as well?
I'm sorry, maybe I'm doing wrong words on it.
The
She
meter,
has the-
maybe she's on
She
a,
has the, what do you call it, with every 2 days, they change it?
yes, that's an insulin pump, that's
That's a
right.
pump, yes,
That's
that's what
right,
she
that's
has.
right. And then she has a meter to check her blood sugar too.
Yes.
Some of the pumps have the meters built right in.
I was confused about that, okay.
Yeah, some have the meters built right in, but all insulin pumps have a meter that communicates with them. So sometimes they'll have them clipped to their belt, and then they'll have a meter, and that it beams the information right to their pump. But that's a teachable moment, because you always need to carry a rapid-acting glucose source with you at all times, because sometimes children don't feel their low blood sugars, and that's called hypoglycemia unawareness. And that happens more frequently with our little guys. They really don't know. So their parents become very good at recognizing how they look and how they act. My son used to go very, very pale, and he would look like he was just running out of gas, and he in fact was. And so we would know to check his blood sugar. And blood glucose meters only came in about 10 years before my son was diagnosed. And I remember thinking, what in the world would you do without these meters? You know, they are so great. In fact, when my son was fairly newly diagnosed, a couple of months in, he faked a low blood sugar because he wanted to get a
I
treat.
was just going to say, my grandson has already started.
Oh, they're so smart.
He's
They're so
usually
smart.
right, and he had
Right.
insulin in
Mhm.
school, and he
Mhm.
was right on target, but then he'll Nana, I really think I'm low. Are
Yeah.
you sure? Just like when we went to the nurse.
But that's that's why we make him check.
Yeah, and then-
I mean,
and
he's
we
not,
check
unless
too.
he's collapsing on the floor.
Right,
And
right.
we have all started to be able to tell, he does, you can sort of sense it, see it, you know, he says, I'm
Right.
feeling low, and you think, okay, this is probably true, but we
Yes,
still make him check
yes,
every time.
yes,
because-
yes. Children are so smart. They know that in a heartbeat they can get everybody in the room's attention to do handsprings across the room. And thank goodness we have meters, because we really know. The other thing too is when children are first diagnosed, their blood sugar has been very high for quite some time. So initially they may feel symptoms of hypoglycemia, but they're not actually low. So, and those symptoms go away soon as the blood sugars start to normalize. But then they don't start feeling those, those low blood sugar symptoms. So thank goodness we do have meters. And we usually say to treat children when their blood sugar is less than 75 points or milligrams per deciliter. And the treatment is based on the children's size. So the little ones would get about 7 grams of carbohydrate, up to our bigger kids that need 15 to 30 grams of carbohydrate. Each glucose tab is about 4 grams of carbohydrate, but there's all sorts of glucose treatments out there. If you want to see the most number of flavors of glucose tabs, go to Marathon Sports, because the runners use glucose as well. I've never seen so many flavors of glucose tabs in my life. And my son was thrilled to know that, other people use glucose tabs besides just him. There also are some glucose tabs that look like pixie sticks, the pixie sticks that the kids, with the sugar and you dump in. We actually just got a bunch of samples of those at work the other day, and those have about 10 grams of carbohydrate in them. So there's all sorts of things that are out there. The other thing that our children will carry with them are like the mini bags of Skittles. And around the holidays, around Halloween and around Easter, you start to see those small candy sizes come in. And that's great. That's the way we should all eat candy, because those sizes are really the perfect size. So I have had some families buy those in bulk and just stick them in the freezer. We do have to be careful with some of those things, though. They're very tempting, because those little packet of Skittles can be awfully tempting in your pocket, whereas glucose tabs, not so much. You'll have the glucose tabs if you're really low. But some children will carry those. It's a little soft packet, it's small, it's about 15 grams of carb, and it's oftentimes just the right size. So even though my son is grown now, sort of to honor him in a little bit of a way, I always have glucose gel in my purse. And whenever I open my purse, I think of my son. I don't ever go anywhere without a glucose treatment, because you never know, you might run into somebody that would need that anyway. because they don't go bad. You know, so if you just keep it in there, then you'll be comfortable that, oops, he should have put that in his bag and he didn't. But you know what? I'm the adult, and so I'm going to make sure that I have that in there. In terms of a low blood sugar where the child wasn't responsive, should we talk about that?
I was just gonna ask that.
Okay, so that's the scariest scenario. But there are things that we can, you know, certainly do with that. That's when emergency glucagon comes into place. And have you each seen an emergency glucagon kit? They're usually in a hard plastic kit with a syringe and the glucagon in it. They're usually bright orange. Glucagon is a hormone that's also made in the pancreas. A lot of people think glucagon is a sugar shot. It's not. Glucagon is a hormone that causes the liver to release the stored form of glucose, which is glycogen, and it raises the blood sugar. But it can take 15 minutes or so for that to happen. There is a sugar shot, but that's IV dextrose, which is given in an emergency room situation, and that's intravenous. So I don't want you to mistake the two. Because glucagon is a hormone, it can take about 15 minutes or so to work. Glucagon is produced in the pancreas, and just because children have type 1 diabetes because their pancreas isn't working well with insulin, it still does make glucagon. It's just that when you and I, if we have a low blood sugar, our body turns off our insulin. Children receiving insulin can't turn it off, okay? So sometimes their glucagon isn't responding quick enough, and that's why we give it. That's why we administer it. Glucagon is based on their weight, so that will be prescribed by your diabetes team. And it always comes in a kit with a syringe that has diluent in it, or liquid, and then the vial of glucagon is a powder, and it hasn't been reconstituted yet, and has a very nice long shelf life because of that. So you always want to check the date to make sure that it hasn't expired. But in an emergency situation, you would uncap the syringe, uncap the vial, put all the diluent into the glucagon to reconstitute it. It takes seconds to dissolve, and then you would draw up the dose based on what the team prescribed. I tell our families that when those glucagon kits expire to practice reconstituting it, because hopefully you'll never have to use it. In the 23 years my son has had diabetes, we've never had to use emergency glucagon. So if your families could let you practice with that, I think that'd be very good too. Because in an emergency, it's scary. You know, you haven't used it before. You don't want to use it. The other thing that glucagon is wonderful for, it's a little insurance policy. It can be used if blood sugar's low, but the child's still awake and alert, but he's got a tummy bug and he's vomiting, and he can't even sip ginger ale. In that situation, you're going to reconstitute the glucagon the way you normally do, but you're going to give him a much smaller dose. And again, that dose is determined by, you know, by his diabetes team. So I don't want you to be afraid of glucagon. Glucagon really is your friend. We hope not to have to use it in an emergency situation, but when we get these pages throughout the winter with children with tummy bugs, they're so thrilled that they have glucagon at home because it can save them a trip to the emergency room.
I recall when my daughter, my granddaughter, she was in Ireland and she actually totally went out. But I said to my daughter, what do I do if she was laying on the floor, but she's still responsive? She said the quickest thing was to put, I think it was maple syrup or something on her tongue. But that, what is the most instant response?
Well, the best thing is glucose gel. So I would keep glucose gel in the house. Because if children are sort of woozy,
Yeah.
you don't really want to put juice or anything in their mouth because they could choke.
Right.
But glucose gel, if you lay them on their side, sort of like this, and you squeeze the glucose gel in, it's going to absorb just through the mucosa of the mouth.
Is that like frosting or something like that?
Well, glucose gel is glucose gel. It comes, yeah, what I would do is go to your local pharmacy. It's with all the glucose tabs. It's fabulous.
Oh, okay.
Because even sucrose has to be converted to glucose by the body. Glucose is the fastest acting. So you're going to squeeze a little bit in there and they can come around. Yeah, sometimes they're not completely out, but they're woozy and you're worried about giving them juice to drink. And that's when glucose gel
And that's
comes in.
instant.
That's very, very rapid. Very rapid. The brain is the only organ in the body that has to have a ready source of glucose. Every other organ we can use our fat stores for energy, which is what ketones are. Have you heard the term ketones? When our body cannot use the food that we're eating for energy, it has to revert to our fat stores for energy. And when you burn fat, you produce ketone bodies. Now, in the absence of insulin, ketone bodies can change the pH of the blood, and that's called diabetic ketoacidosis, and that is a medical emergency. And children are often in diabetic ketoacidosis at the time of diagnosis, unless their diagnosis was mercifully picked up early. But often children are in DKA. That's what that's called.
I know this is something I sort of understand, but when they're low,
Yes.
when they're feeling pain,
Right.
How did we get to that? How did we end up in that situation? Is it because they were given insulin and didn't eat? Is it because
Yes, there's a bunch of reasons actually. It always has to do with too much insulin, but the insulin dose for the food could have been right, but it could have been that then they went out and exercised, or they covered for a certain amount of food and they didn't eat their breakfast. They didn't eat everything. Oftentimes it's sort of energy expenditure or too much insulin based on, oops, I calculated those carbs wrong, or I didn't finish it all, or I have a tummy bug and I'm not absorbing the food well. Now that doesn't happen too often. Usually the children are, they're acutely ill, and so we sort of are really watching them. And when children are acutely ill, their blood sugars tend to go up. So it's not usually a problem, because when our body is stressed, we become more insulin resistant. And that's why you have your diabetes team contact information all the time, because your team is available 24/7. As it will be for you guys, even though the diabetes team is in Florida, you can always page them, because they do make themselves available 24/7. But yes, when the blood sugar goes low, the brain is like, I ran out of fuel, and it's just going to check out. And that's why you lose consciousness, or it can cause seizure activity too, which is very alarming. So we want to prevent that as much as we can. Insulin regimens now, a basal bolus insulin regimen, and an insulin pump does reduce the likelihood of those lows. Some of the insulins that we've used in the past that have a very big stiff peak were more problematic in terms of causing lows, because if you didn't absolutely eat a meal by a certain time, your blood sugar was going to go low. Now we have a little bit more freedom and flexibility in terms of when we eat and how much we eat. And if we've got the pump settings right and the Lantus dose right, children really should not go low if they don't eat.
So it would be better to be too high, obviously, than too low. But so the consequences of being too high is that's a more long-term thing than
Exactly.
being low. You're going to have these consequences happen very short.
Exactly, and it's a fine balance, isn't it? Because long-term, the high blood sugars cause diabetes complications, which we completely want to avoid. With little children, we err on the side of running them a little higher, but what we target is an A1C level that's appropriate given the age. So an A1C, that's called a glycohemoglobin A1C, is a test that we do, and we can get it with a finger prick, which is really nice. We don't even have to draw the blood for it. It's a test that we do when the children come to see us, and it tells us what their overall blood sugar average has been for the past 3 months. And depending on a child's age will determine what the A1C goal is. So if you don't have diabetes, a normal A1C range is 4 to 6%. For our youngest, our babies and toddlers, we want their A1C under 8.5, and then as they get older, it goes down to 8, 7.5. And adults, ideally, for long-term health, the goal is less than 7%. So the 6 to 7% range is where we would like for long-term health.
So right now, I know down there they're feeding him and then taking the blood, and then giving the insulin based on what he
finished.
What it's showing, yeah.
Yes. How old is he?
5. He'll be 60
Okay.
end of June.
Okay, so I'm sure they're checking his blood sugar before he eats, because otherwise it would go up too high and they wouldn't get the calculation right. But they are probably waiting to see what he eats to dose him. In time, they will give him his bolus, his injection, or bolus via the pump before he eats, because that's the best thing to do. But initially, if children are unpredictable eaters, and especially for our babies, we dose them after we eat. Continuous glucose sensor trials have shown us, however, that it's best to get that insulin into them before they eat because of what happens after they eat. Blood sugar goes up quite dramatically after we eat, especially after breakfast, which is a time of day we're most insulin resistant, and because the type of food we tend to eat for breakfast in our culture. We tend to eat cereals and high glycemic index foods, which I hope we're going to get away from. But that's the way we eat right now, and as a result, blood sugar goes up quite rapidly after children eat. But with our little ones and our newly diagnosed, it's sort of, I don't know what they're going to eat, so they'll dose after.
I have a question. All these things are happening during the day. What happens to a child that has diabetes during the night when he's sleeping? They go to bed, that's it? Nothing happens?
Well, usually children initially, oops, sorry about that. Initially, we are having our families check blood sugar in the middle of the night so that we can get these doses just right. And once they're stable overnight, we'll say, okay, people can sleep, which is the goal, for people not to be exhausted. But it's always prudent to add a blood sugar back in after you've had a particularly active day. Or, let's say, it's been the first beautiful day out, and now that the days are longer, children are going out after dinner and riding their bikes and being very, very active. We also train families how to adjust the insulin dose based on activity, too. So families will temporarily decrease basal settings on an insulin pump overnight after particularly active days. But our new families, we help them with all of that. We do the dose adjustment with them early on to see how the particular child responds.
That's something that really concerns me when the kids sleep overnight. We're at a point where their parents, as long as the 10 o'clock testing and everything has been fine, they don't check him again until he gets up in the morning. But it makes me very uptight not to do a 2 o'clock.
Right, right.
And my kids say, if you do a 2 o'clock and you adjust him, you'll mess him all up, because he could be high or low at that point, and that's where he's, that's how they programmed
Right.
the
Right.
pot. So, but it's one of, and so I have started.
You don't sleep really well.
But I've started not encouraging them to sleep over, which my daughter
Yes,
doesn't
I
like.
do the same thing. Yeah.
It's so scary.
It's so scary for me, and she doesn't get it, and she wants the break, and I understand that.
Right.
But I have this middle of the night
Right, right. Well, you're in very good company, and I think because if you're living with a child every day, you get to know what their normal routine is.
Right.
You've done enough overnight checks so you can say, no, I know his blood sugar is stable in this situation.
During the day.
Right.
But nighttime's different.
Right, right, because he's not with you every night. So I would talk to your family about that, because that's a very, very valid concern. A lot of our families, even when we say, okay, you have our blessing, things are stable overnight, you don't need to do the 2 a.m., and they're like, I'm going to wake up and I'm not going to go back to sleep till I know anyway. So some families do it for their own comfort. What you can do is you could say, clearly, if the child is below X, I'm going to wake him up and feed him something. Or if he's above, above this number, we need to do something too. But anywhere in between, we're just going to let it be. When children's blood sugars are above 250, especially if you're on an insulin pump, you should be checking for ketones. And the ketones will tell us whether that insulin pump is working. That's why you really have to check ketones a lot when kids are on insulin pumps. And if the ketones are elevated, it's an indication that insulin isn't getting in there. And then we have our kids on pumps, you have to correct them by injection and change out the pod.
We never check the ketones. I mean, he says it, but we
Right,
don't do it.
right.
We did when he was first diagnosed.
Right, right.
But so how does it tell us if the pump, right now we only know if the pump isn't working, if it buzzes or beeps, or if it's a length of time and it's
Right,
going in one direction.
right. Well, if the blood sugar is very high,
Right.
then you start wondering, why is that blood sugar high?
Right.
Is it high because we miscalculated the carb amount? Is it high because, oh shoot, we forgot to give him his dose at dinner? Or, and the pumps, of course, record all these things, so you can look and make sure you gave him the bolus. So we'll say to people, if they're above 250, especially if it's unexplained, you really should check those ketones, because it could be that there's a kink or something in that catheter and they haven't been getting their insulin. And that's very, very important to know.
So if there were ketones, then that would show that the pump isn't working and you're not getting it.
What our protocol is if the ketones are greater than 0.5, and there's a blood ketone meter out there, anywhere up to 0 to 0.5 is considered normal. If it's above 0.5, what we'll say if they're on an insulin pump is you need to correct by injection and change that pump set. Because it could be that there's a kink in the catheter at the tubing is leaking. And so you want to make absolutely sure, especially for 8 hours. If he went for 8 hours without receiving insulin, yeah, that puts him at risk for, again, this DKA. But even if you were checking that blood sugar in the middle of the night for informational purposes only, so that you could feel like, okay, I can go back to sleep, I know he's okay. If he's not below 75, and you don't have to treat the low, and then if he was above 250 and you check the ketones and the ketones are 5, and then you can go back to bed and rest. But I can totally understand why you're nervous about that. In fact, that's the Holy Grail. The Holy Grail is, what are these blood sugars doing overnight? And can we all sleep? And it's one of the things about continuous glucose sensing that that appeals to families.
Do you suggest to give them ice cream or something like that, which would, if they weren't really high when they were going to bed, to give them something like that would cover them a little bit more through the night?
Well, we used to, on the older insulin regimens, especially if they were on NPH at bedtime, you had to have a bedtime snack, because that NPH was going to peak in the middle of the night, and you had to give them something to sustain them through the night. But now on these insulin pumps or Lantus' job is to keep that blood sugar absolutely steady. So if his blood sugar is good overnight, and he hasn't had a really active day, et cetera, then his blood sugar should really stay the same overnight. So you're not required to have a bedtime snack on that regimen. Again, if they've had a really unusually active day, what we'll say is give the child a bedtime snack and don't cover it with insulin, because they were at Canopy Lake Park for the day and they were running around like crazy, and we want to make sure that they're not going to go low. And then again, you would check them at 2 o'clock, and you're going to give yourself a little cushion overnight for particularly active days, and you always err on the side of running them a little bit higher, because you learn in those situations. When the child wakes up the next day or 2 o'clock in the morning is perfect, you're like, yep, for that level of activity, we always have to give him a snack. Or no, I guess we really didn't have to give him a snack because his blood sugar was a little high. But isn't it better to run him a little bit high, and so that you don't have to worry, especially in the overnight hours? And in time, everybody gets to know their particular child and how they respond to activity.
Because they'll be here on vacation, and that's.
That was my next question.
We're going on vacation
Yeah.
for a week, and we're going.
So how does Papa and Nana spoil the grandkids?
Not with
We
food.
can't go for an ice cream or
You can go for an ice
My
cream.
grandson,
Yeah.
who's the same age, and he has only been diabetic a little bit longer, or been diagnosed a little bit longer, is coming home today from 10 days at Disney World.
Wow.
He's the oldest of 3. They have a 3-year-old and a 21-month-old and a 5-year-old newly diagnosed diabetic.
Wow.
He did everything. He ate everything, he went on every ride, he
That's
had
fabulous.
the same Disney World cup he had last year and that he'll probably have next year.
Mm.
That's what they do every year. And they were nervous. It's not that they weren't nervous, but they were determined that it wasn't going to change this vacation plan, and it didn't. And they didn't, they did their right there at Children's, and they still are at the phase where they're sending emails and in
Yes.
regular touch with their team, but there were no glitches, there were no bumps.
Well,
you
planned
just make the adjustment up or down depending
I
on
mean, my daughter-in-law is a statistician. Charts and
try to stay in that
plans.
target.
That's the one thing, like if you have them, if I have them for any length of time, I plan. We decide to go out to lunch, and he sort of has to tell me at 10 o'clock what he thinks he's going to eat. We get there at noontime, he says, no, I don't want, I guess I want a burger. It's too bad.
Yeah.
You know, it
You're on my
just-
watch, you're having this.
You're having nuggets. Yeah.
Yeah, absolutely.
But wonderful, thank you.
Well, my little 13-year-old granddaughter is absolutely remarkable because at 4, when she was diagnosed, she fought it so she didn't want to have a shot. She would run, she would scream, she would hide. She was terrible. And now she takes over the babysitting for her cousin, who at 16 months came down with it. She babysits, she does his blood sugars, she gives his shots. She is amazing, absolutely amazing.
Wow.
And she goes to diabetes camp every summer for like 10 days. It's her favorite thing. She says to her mother, you just don't get it. Everybody is like me there.
Yes,
Everybody
yes.
is
Right,
like me.
Zach's going this summer
Yeah.
too.
Yeah.
First time I hear it's wonderful.
Yeah, it's her greatest thing is to go
Sounds
to
like we have
diabetes.
to hire her for this.
Honestly, she does babies. Where do you live?
Watertown.
From Watertown. Yeah,
Brooklyn.
she's Brooklyn. She's amazing, yeah.
I'll give me your
Yeah,
cell
you
phone.
ought to get in touch with her.
Sounds like she's a great role model, too.
She is, yeah,
Yeah.
she is, she's fabulous,
Yeah.
and she, you know, of course, puts in her own insertion. She's been picked it's probably a year ago, Mother's Day. They live downstairs from us in a condo downstairs. And I was babysitting, and it was very quiet downstairs, so I went down, and I saw her on the bed, and she was like twisted, and I said, Casey, what are you doing? She said, I'm putting in my insertion for my mom for Mother's Day because I've never put it in my bum.
Oh.
But she's unbelievable.
That's terrific.
That's great. That is really great.
Now, can I ask you a question? If you have diabetes, are you more susceptible having another autoimmune? My little grandson now is also allergic to peanuts. Not other nuts, but just
Right,
peanuts. And
right.
that came up even before he had the diabetes.
Right.
Do you find that more common in children?
There are other autoimmune, and nut allergy is not, but there are some other autoimmune conditions that we screen for regularly, and all diabetes programs do for children, because there is an increased incidence. There's an increased incidence of celiac disease, which is a wheat allergy, and then you have to go on a gluten-free diet. And then there's also an increased risk for autoimmune thyroid, which is easily treated with medication. So with just an oral medication. So we do screen for those and look for them.
Really? So that's interesting. Now, you did say, I think, in the beginning that 75% do not have
A family history.
Family
That's right.
history.
That's right.
What if thyroid is in the family? I know.
Well, we were told, because I actually have autoimmune thyroid myself, and I asked that same question, and they said, well, if you have diabetes, there's an increased risk to develop thyroid, but it doesn't work the other way around. Now, they continue to do research on these things, so we all have to keep abreast of that. And I think that one of the best resources for keeping abreast of all the latest research is JDRF.org. It can be overwhelming when the diagnosis is new to go online, because there's so many websites. So we actually caution our families to take it slow, because there's so much information that you need to know, and you're going to get a lot of that information from your team, when you're first diagnosed. But over time, if you want to keep abreast of things like that, I find that is a fantastic source.
Right, and a lot of things have changed. I mean, originally, when I was a nurse, and when I was in training, they said it has to be on both sides of the family and all that.
Right.
And of course, now you're saying
Right.
75%.
Right,
That's amazing.
right.
Really.
Yeah, that's true. Yeah,
Yeah.
no history at all in my family, and with most of our families,
No, but
with
what about
75% of our
But
families.
it's still a trigger, right? Even if you
They
have-
believe that there is a genetic predisposition and that there is an environmental trigger. That's been a hypothesis that has been
I wanted
around.
to speak to that environmental thing, because I was going to say next, so I'll talk about it.
It's been a hypothesis that's been around forever, And they still haven't shown it, but they feel that that's the case. There's not a single gene for diabetes, there's many. And even in identical twin studies, the identical twin doesn't always develop type 1, so they're not quite sure of the mechanism, and that's one of the things that they continue to study. There are parts of the world and parts of even our country where the increased incidence is higher. So it's actually higher in the colder states, highest in the world in Finland. The incidence or the number of diagnoses go up in the cold weather months. And it's one of the reasons why the hypothesis is a viral trigger, because in the cold weather months and we're all together, we spread germs a lot more easily than we do when we're outdoors in the summer, because we're not all cooped up in the same, in small environments, so you're not spreading germs as easily.
My observation has been where my granddaughter, who picked it up 7 years ago, across the street from her, a little girl picked it up. She was about 30 now, and she was about the same age. Down the street, another one got it, and across the way, all within a mile, 4 people got type 1, and they all had Lyme disease. Just saying. You never know if something like that could be in them, and that would have triggered it all. It's just very
They all had
interesting.
Lyme disease.
Everyone had Lyme disease.
Well, they are looking at clusters now, which I think is really a wonderful thing, because type 1 diabetes has not been a reportable condition. The Centers of Disease Control have certain things that are reportable because they're contagious. And so there is now a diabetes registry that that Children's Hospital is participating in that, and some other centers are participating in that, so that we do get an idea of what is the incidence. And to look at, are there clusters? And if there are clusters, why are there clusters? So there are some more studies that are going on in that regard, and I think that's a good thing.
And now, I'm sorry, go ahead.
Is the theory that there's a virus or there's whatever it is that causes this, that just kills the pancreas like that? Or
Well, it sort of triggers the whole autoimmune condition, and the autoimmune condition makes a mistake and sort of knocks off a certain part of the body that should be functioning, like whether it's your thyroid or whether it's the insulin-producing cells. So they think there's a trigger that sets this autoimmune process off, but it just runs amok, and it goes after something that it should not.
So Lyme disease, so you had Lyme disease like 2 years ago and not be diagnosed with diabetes?
I haven't heard of a link with Lyme, and I also don't know, and I don't think anybody knows yet, what the duration is either. Like, when did the trigger occur, and then how long did it take for the diabetes to manifest itself? When my son was diagnosed years ago, they really felt that it was a very rapid process. They thought it was very rapid, that there was rapid disintegration or rapid attack of these cells, because without insulin, you become symptomatic very quickly. But the thinking is now it can be actually a longer process than we think, and it could be maybe individual too. So again, these are things that they continue to research, because of course one of the goals of JDRF is to prevent type 1 diabetes as well. Not only cure type 1 diabetes, but prevent it.
Well, do you think the possibility of having the peanut allergy weakened the immune system that could have triggered the possible?
I can't answer that, but I know nut allergies are very, very common. And we'd have to look at, what is the percentage of children with nut allergies having type 1 diabetes as opposed to the rest of the population. I don't think it's more.
I remember reading in the newspaper or magazine probably about a year ago, but there was a higher influx of diabetes in like Weston, Wellesley, Newton, with no real explanation for it, but have you heard that also?
Well, that is one of the things that started all of this on the cluster. I don't know that the incidence is higher. What I know is that in these communities, they came together and they became very active. Who knows if the incidence isn't just as high in other communities, but they didn't band together to call attention to it. So I think it's a fabulous thing that they called attention to it and are making people look at it. For example, I know Sudbury, for example, which wasn't in that cluster, they have 27 families that have children with type 1 diabetes, but they weren't part of the group that decided to look at that cluster. So I think you really have to look at the incidence, and that's why nationally you have to have a registry, to really look at it.
Have you heard anything about food preservatives being in the picture?
I have not. But they continue to look at toxins, toxins that could be triggers and things like that. Some of our docs just were at a conference that looked at that, and are thinking of doing a research trial on that as well. Like, what are toxins in the environment, and they're increasing it.
When my 16-month-old grandchild was brought to the hospital and diagnosed, the nurse said to him, I used to see 5 to 1 or 2 a month. She said, now I'm seeing 5 to 8 a week.
Mm-hmm. New diagnoses? Well, the number of diagnoses at Children's has remained pretty stable over the many years that I've been doing this, and we usually diagnose about 200 new cases a year. One year we had, like 250, Lauren? And that alarmed us, but it did go back down sort of the next year. I think in the state of Massachusetts there's about 450, and that's the entire state, because there's a Springfield area and everything else. But Children's sees the vast majority of children that are, diagnosed sort of in this area, and so our rate has stayed about the same, and we do watch that.
I asked you about that thyroid condition again, because recently our grandson has been diagnosed as having a thyroid problem as well. Now, the thyroid problem does exist in both sides of the family.
Okay.
Diabetes does not.
Yeah.
Just wondering what that. And in fact, we know families not connected to us, but families where a person who has thyroid problem doesn't have diabetes.
Right,
They're the only
right.
member of the family that doesn't have diabetes. Everybody else has diabetes except the 2 that have the thyroid problem. We seem to have kind of the reverse.
And do you see, as I say, my daughter and her husband, they have the child with the diabetes, the 13-year-old. Now my son and his wife, they have the 16-month-old.
Right.
Is that unusual that you would, if one of my other grandchildren, the 13-year-old has a brother and a sister, if one of them came down with that, to me it would be more understanding, well, one in the family, another one in the family.
Right.
But for this to be, it kind of is strange to me. Is there any explanation, or do you see this happening?
I don't know that there is yet, but I do know that they're continuing to look at that, because certainly we want to look at how we can prevent it and why it's occurring.
Do you see
A lot of sibling diagnosis?
No, see, it's not one of the, it's 2 separate families, but
Yes. Related by blood, or?
Yeah, right. I have 7 grandchildren.
Yes.
Okay, but now my daughter and her husband, I'm saying, they have a child with diabetes.
Right.
Now my son and his wife have a child, so they're cousins. They're not
Okay.
in the same.
And that was the
family.
first generation where there was any diabetes. There wasn't
There's no
prior.
diabetes whatsoever that
in
we
the
know
family.
of.
Yeah.
No cousins, aunts, uncles, anybody has.
The incidence of type 1 is going up. I do know that. And when my son was diagnosed 23 years ago, what they had told us is that if neither parent had type 1 diabetes, 95% chance none of your other children would have diabetes. But that's gone up now. Now it's only about 80%. So there is an increased incidence of type 1, and we are seeing more siblings now. Fortunately not a lot. But again, 80% chance if neither parent has type 1 is the latest statistic, but that has gone up.
If there's a virus or something that triggers it, siblings all get
Right.
they all get the same thing.
Right.
Your
Right.
5-year-old has a virus, the 3-year-old's going to
Right,
get it
right.
too. So that, whether it's in their daycare, half the kids in that daycare can.
Right. But
So
everybody
there
has
would be that-
viruses
the
every
genetic
year, so.
predisposition to diabetes.
Right.
Can I ask you, what brought the 16-month-old to the hospital?
That's
Like,
what I
how do you?
was gonna
Well, it was very evident that they had the twins, and it was very evident that he was wetting through his diaper where the other one wasn't. You'd give them both a cup of juice, milk, or whatever, and one was gulping it down. And of course, they had the cousin who had the diabetes, so.
So it's the same
So when the
symptoms that we see
symptoms
in the
came,
older kids,
when the
but it
symptoms
was-
came like that,
Yeah, I'm sure.
they said,
They
oh.
weren't twins.
But
It
that's a
wasn't
very good
necessarily
point,
linked to
because
that.
these babies, it's very difficult to pick it up, or if families aren't savvy about what the, I'll never forget one mom telling me of a toddler that she knew something was wrong when the baby crawled over to the coffee table and took the flowers out of a vase and drank the water. And she said there's something completely wrong with that.
Being in the desert or something.
Yeah, exactly. So that's the problem with our babies, is it's really hard because they're in diapers, and if it's in the summer, people will think, well, it's, they're just thirsty, and if they're not aware about diabetes. So thank goodness they pick that up quickly.
Could that
Should-
be the reason why they are diagnosing more? Perhaps kids just have it and we don't know about it? Or would it become obvious at a certain
Well,
age?
eventually they would die.
Yeah, they
Well,
get
if they
very sick,
get-
very
Well,
sick.
My niece got it, and she's 30. She had just found out that she has it. So she must have had it for a while. It's not
Is it
something
one or
that-
two?
It's one.
With type 1, you're very symptomatic. Type 2 diabetes, oftentimes people have it for 10 years without noticing, because
This is one.
you can, type 1 diabetes, you're going to get really sick. Without insulin, you're going to get very sick pretty quickly.
Can you get that old?
Oh
Before
yes,
it's
yeah.
diagnosed?
Mary Tyler Moore is sort
That's
of one of
right,
the
she was in her
famous
30s.
famous people in their 30s, and type 1, which is sort of why they've changed the way, what they call it, type 1 and type 2. It's no longer juvenile, which is the way they used to do that.
Assume that you grow out of that.
That's right.
So many people
Exactly.
That's
hear
right.
of
That's
juvenile
right.
diabetes, and
Right.
say, oh, thank goodness he'll outgrow
Yeah,
it.
right, right.
Did you say a
Right.
majority of a certain age group, like under 5? Or you said it usually, they're diagnosed they come down with it more children under the age of 5?
That's the fastest growing population of the new diagnoses is under the age of 3. But children, right, middle school is another big time when a lot of children get diagnosed.
Do you know
Should
your daughter, or is it your son's children?
It's my son's children.
What are they doing about watching the other two? Is that just a watch, or is
They
that-
test them.
My
My daughter
daughter
tests
say every
them.
now and then, my 3-year-old will say, Mom, pricks me again.
Yeah.
I mean, she
Oh,
just,
she's doing it herself.
you know,
Yeah, type
if
two.
he's,
Our
if,
grandson's
you know,
mom
if he
suggested
wets the
all of our
bed, or
children,
if he
they're
seems to
not
have eaten
related,
more or had more to
be
drink on any
brain
given day, she gets nervous and she'll test him.
Our grandson has a 4-year-old sister, so, yeah.
But it's just, I mean, they don't. I was shocked to find out, because I remembered when I brought kids, we're all grown up now, but when we would go to the pediatrician for their checkups, every time you went, they peed in the cup.
Mhm.
But they don't do that anymore.
They don't?
Like when I said, "But didn't they check him when he went for his checkup in July?
Right.
Didn't, and she said,
Right.
no, they don't routinely
Right.
do that.
Right.
At well-child visits, which surprised me, but that's
Well,
normal.
it's such a symptomatic thing. They could be completely clear one week, and then the next week they could, if they develop type 1. But getting back to the siblings, there are some tests that they can do to look at antibodies. And if you have a certain level of antibodies, pancreatic antibodies or insulin antibodies, that can be predictive of developing diabetes within 5 years. And so sometimes families will choose to have the antibody test done, but you don't just have it done once, because sometimes it takes many, many years for the antibodies to develop. So over the course of the years, there's been a variety of intervention trials out there to look at those that have antibodies, if you can prevent it from developing to full-blown type 1. None of them have been successful. And again, I did have my 3 children tested once. I didn't want to put it through it every year, and it was negative. I knew that I would pick up, excuse me, the symptoms, and I didn't see any reason to check them if there wasn't anything we could do to sort of prevent it. So, and different people have different philosophies about that. I was going to assume that everything was well until I saw that maybe it wasn't. So that's something that you could talk about with the diabetes team, whether they thought it would be worthwhile to have these things checked. And every now and again, like at camp, I know at camp in the summer, when children are checking into the diabetes camps, especially TrialNet is a study that has been going on for some time, and they have had several intervention trials, and sometimes they'll actually recruit at camps or something, and oftentimes they'll look for families, relatives of those with type 1 diabetes. JDRF has a fantastic registry that you can go on, and you could actually put your child's gender and his age and where you live, and then you would get an email saying there's going to be an intervention trial and your blah 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 that your child might be or a sibling might be suitable for. So that registry some families choose to do just to keep abreast of what intervention trials there are out there.
Is your son with diabetes the first your first child?
He's my oldest, that's right.
What about
Yeah.
He's the oldest in that family.
And they're first,
The
right?
granddaughter that's 13 is the oldest of 3, but
Not mine.
the twin has a 5-year-old sister.
Oh, so
And the other
That's
twin
just
doesn't.
further,
that
yeah.
Did I
one
goof it up when it
doesn't-
fell?
Does not show any symptoms of it. They're not identical.
But I think that, for, we have one sibling,
yeah, she just turned 4 yesterday, and
That-
he'll be 6 in June.
that you get to, like with her grandson, you know the symptoms,
Right.
the parents know the symptoms,
Right.
so that they would, you can't prevent it,
Right.
but they would know there
See
was
it.
something that they needed to look into further before she got as sick as, I don't know how sick her brother was, but before,
Yeah.
probably before she got as sick as he was, however sick that was.
He didn't actually get sick, he was just, wouldn't stop peeing.
Mm.
And she
That's
thought
what
actually he
happened
had a
with our
urinary
grandson,
tract
too. He
infection
started
type
wetting
thing,
the
you know,
bed.
and once they pricked his finger, it was,
Call emergency.
Yeah.
Right, that was the same thing. They thought my granddaughter was 13. That's when she was 4. They thought it was a yeast infection, urinary tract. That's
Yeah.
how it's,
Mhm.
in the very beginning, yeah.
hmm.
Well, that was a good pickup by the parents.
Yeah, she called and said.
Yeah.
She went in and they tested, and they said, we're calling the hospital, you can go right now.
Right,
It's
right.
emergency situation.
Should we talk a little bit about treating high blood sugar? There's some handouts in here. I just want to make sure we cover the things you guys want to cover. So the symptoms of hyperglycemia, so hypoglycemia is a low blood sugar. Symptoms of hyperglycemia, and that's what we were just talking about, the frequent urination, the excessive thirst. If they've had hyperglycemia for some time before diagnosis, there's weight loss. So these little ones, after they're diagnosed, they're ravenous. So the thirst goes away because finally they're hydrated and they're getting insulin, but then their body's trying to make up for that weight that they didn't, that they either lost or that they didn't gain. And so they're ravenous. And initially it's pretty nice when they're on this basal bolus regimen because we can sort of feed them at will. Again, your diabetes team will give you a range of what a healthy carb target should be. But initially, for those first couple of weeks, we'll say let them eat because they're quite hungry. And our little ones, oh my goodness, sometimes you just can't keep them full, and it's heartbreaking to the parents. So it's very nice when they feel like they're not on a rigid meal plan, which is how we used to treat people with diabetes. We put them on these very rigid meal plans, which you had to follow, and you had to eat by certain times, and the insulin had to be given, and you didn't really have any flexibility. So even though it's very, very challenging, it's changed significantly for the better over the years. I'm just going to quickly go to the.
Is it regimented easier though?
I'm sorry?
Well, it's easier for you.
Yeah, I was
but
gonna
for
say.
a 5-year-old, it's not so much fun.
You can still put them on. You can still have a regimen. In fact, I
Just
saw.
for safety, I'm thinking.
Yeah, no, I think that's perfectly fine, but you can have some flexibility in terms of the quantity of the food, and also you don't feel like, oh my goodness, we are all out right now and it's 11:45 and we must all stop and eat right now, okay? So instead of saying, okay, we haven't quite arrived where we're going for our picnic and we brought this, let's wait 15 more minutes, we can totally do that, okay? So that's what I'm talking about in terms of the regimen. I did have a little one in the office yesterday. He's 3 and his 18-month-old sister were in, and Mom was telling me how having diabetes has actually gotten them on a better regimen because their children used to graze all day long. And she's found now that this is actually sort of a healthier way to eat. She used to let them eat at will, which is sort of a cultural thing that's happening in our culture. I mean, we're so busy taking kids here, there, and everywhere. And she's found that it's actually pretty nice to be on a regular routine, knowing about the 3 meals and the 3 snacks. So that's perfectly fine, and you can certainly have that, but you don't have to be looking at your watch going, oh my God, I've got to feed him right now, and everybody has to stop.
Like you said at the beginning, counting carbs. we all should be doing that, so that's what, my daughter was saying the same thing. She
Right.
said, well, now, we're all gonna eat healthy too,
Right.
not just you.
Well, it's so amazing because I think just in one generation, the portion sizes have gone up so much that people don't know what a portion size is anymore. And one of the things that I think was so telling is you go over the border to Canada and the Big Macs and everything else are smaller than they are here. I mean, Americans really have supersized everything. And what has it caused? It's caused really a lot of problems. So people get so educated about it and they're like, oh my goodness, I had no idea I was eating that many carbs and nor was that really good. And what should the mixture of my meal be and whole grains and things like that. So I think that, and I'm seeing a lot of that even with packaging now. You know, there's 100-calorie packs and there's more healthy things and there's more whole grains. And I think we're finding a lot of that. I think it's sort of a backlash. Remember when everybody thought that we should go on a low-fat diet because it was, and what's happened? What's happened is the rates of obesity have gone up in our country, and it's because they took the fat out of everything and they added a lot more sugar. And people have only gained weight because of that. So that wasn't a good thing. The high blood sugar sheet here, just the definition and symptoms. And this is what we were talking about before. So high blood sugar comes about by having too little insulin, eating more than usual or eating more than you've covered for with the insulin, injecting insulin in a site of the body where the absorption rate is slower. I don't want you to worry about that too much, but that is something that the diabetes team would talk to a family about at a particular visit. It's more related to time of day and that sort of thing. One of the important ones is developing a clog in the insulin pump tubing. So that's what we were talking about before. If the blood sugar is very high, why is it high? If you're spilling ketones and you're on an insulin pump, that tubing could be kinked. And so that's definitely a cause of a high blood sugar when you're not getting the insulin. You cut back on your insulin because you're going to go out for a run, but then you don't go out for a run. So exercising too little can actually cause high blood sugar too. Stress is another common one. Usually it's physiologic stress, like being, acutely ill. When we're acutely ill, our insulin need goes up. So our children that have the flu or the chicken pox or they're ill, their blood sugars are usually high because they're under stress. But some kids, emotional stress, MCAS causes their blood sugars to go up. And that's a very individual thing, and we look to see whether that is a consistent pattern, and then we can advise the families from there. Again, illness or injury, hormones definitely affect it. Women and teens that are premenstrual, usually their blood sugars will go up premenstrually, and certain medications cause the blood sugar to go up too. Steroids is the huge culprit with that. Our children that have to go on steroids for asthma, or if they get poison ivy or something, we have to increase their doses quite significantly. So those are things that you would be in touch with your diabetes team for insulin dose adjustment. All our families are given sick day management guidelines and told to page the team if the child's sick and the blood sugars are high, because then we'll help you adjust the insulin dose. Again, high blood sugar levels over long periods of time can lead to the serious long-term diabetes complications, which is our goal to completely avoid. So in a pediatric practice, managing diabetes, the goals are normal growth and prevention of long-term complications. So we hope to never see them, and we do have very good long-term outcomes. One of the most wonderful things I've witnessed has been at the Joslin Diabetes Center, when every year they hand out their 50-year medal. And that's quite a wonderful thing to see, because you think back 50 years ago when they didn't have these meters and all this technology. And it's just so amazing to see this, So you're thinking, well, if they can do it, then we, with all the innovation and all the technology and all the things that we have here, certainly our children can look forward to some very long-term good outcomes. And when you have families that are this loving and concerned and caring and involved, it bodes very, very well for your families. The children that I see struggle, it's because diabetes is 5th down on their problem list. You know, they might be in single family homes, or housing might be a problem, or getting food on the table might be a problem. Those children, that's a tremendous struggle for them. But our children that are well supported and loved by their families generally do very, very well. And there's not a thing that they can't do. One of my favorite books that I keep in my office is called Famous People Touched by Diabetes. And it's just a list of all of with pictures, usually from the cover of either JDRF's Countdown or Diabetes Forecast, about all of these Olympians, with type 1 diabetes, like Chris Freeman, captain of the Olympic cross-country team. Gorgeous, by the way. You got to check him out. Gary Hall Jr., who, how many medals did he win? 10 Olympic medals, hello, after he was diagnosed with diabetes. They didn't think he would be competitive again. He is the honoree at the JDRF Gala this year. And the diabetes champion honoree is Bill Burnett. Bill Burnett started the Cohasset Tri. Triathletes, as you may know, are crazy. They will come from all over the world to do a triathlon. How many years has he been doing it? 7 years. So he got Gary Hall to come and speak to the throngs of people participating in the Cohasset Tri. So that'll be a really neat combination to see Gary Hall get the diabetes, to be the honoree, and to see this Bill Burnett be the diabetes champion. So there are all sorts of people. Last year, my husband was watching the Indianapolis 500 because he and my boys race. My son Chris, who has diabetes, races. Just checks his blood sugar an awful lot before he does. But he called me in because Charlie Kimball, have you heard of Charlie Kimball? Charlie Kimball was like 4 in the Indianapolis 500 racing this car. And my husband called me in because I didn't know, I wasn't watching the race. And he called me in because Charlie Kimball turned into the pit, and the pit crew was like working on his car, and the medical crew is working on him, checking his blood sugar and giving him insulin. And it was just like, honestly, there's nothing that needs to get in these kids' way, because when you see these role models, I mean, it's astounding what they do. Sean Busby, he's a local snowboarder who's ranked nationally. His website is called Riding on Insulin. You might want to check it out. He runs a fantastic thing. I think it's at Wachusett Mountain or Neshoba, but I think it's at Wachusett every winter. And all the local kids can go to that, and that's a really amazing thing. He gives of his time. Nick Jonas of the Jonas Brothers does a lot for type 1 diabetes awareness. In fact, I have a lot of little girls that tell me they want the Nick Jonas pump because he wears an Omnipod pump. So they don't call it the Omnipod, they call it the Nick Jonas pump. So there's a lot of really wonderful people that have type 1 diabetes that are great role models and do a lot to, to raise awareness and to let kids know that nothing need get in their way.
Can I ask you about continuous glucose monitoring along with the pumps?
Right.
Where are we with that? Is that
There are 3 continuous glucose monitors FDA approved: the Dexcom 7, the Medtronic MiniMed continuous sensor, and the Navigator sensor. The Medtronic is integrated into their insulin pump. It's the only one that is integrated into an insulin pump. But a sensor is worn under the skin, much like an insulin infusion catheter. You can usually wear it for 3 to 7 days. The Dexcom 7 is now for 7 days, and that's nice. You only have to change that once a week. And it measures interstitial glucose, which is the glucose under the skin, because it's put under the skin. It's not put in a capillary. Interstitial glucose is very similar to blood glucose, but there is a lag. It's identical to blood glucose in the fasting state, but there's usually about a 15% change or difference between interstitial glucose and blood glucose. Continuous sensors are good for trend information. So in other words, is the blood sugar going up or is it going down, and how rapidly? It will give you a reading every 5 minutes, and it will either beam the information to the pump or beam it to a little handheld monitor, which will tell you what the blood sugar is. And it's a very, very exciting innovation. it has the potential to really transform the way we manage diabetes, but it's in its early stages.
So it doesn't take away the testing and?
It does not. It does not, because you really have to calibrate it. You have to tell the sensor what it's reading, what it translates to in terms of a number. And you would never administer insulin based on a CGM reading. You would have to always check your blood sugar. But it is kind of nice to have a sense of what's my blood sugar doing now, because it can give you warning if your blood sugar is going down, and it also can give you a warning if your blood sugar is very high, and if you're on a pump, you might want to know that. We're not using them a lot in children. A lot of kids don't want to wear them. All of the research has shown that it's been most beneficial in those over the age of 25, and part of that is because they're willing to wear them. And the continuous glucose sensor trials were done in adults, but there are JDRF is involved in funding the artificial pancreas program, which looks at linking a continuous glucose sensor to a handheld computer which operates the insulin pump, so hence the artificial pancreas. You're getting information, and these handheld computers are programmed with very sophisticated algorithms to run the pumps. They're not being used in clinical settings yet. They're research, but we do use continuous sensors in our practice. There's blinded sensors that we'll put on children for like 6 days or so, download them, look at what's going on. It's great to see overnight, if there's a pattern there. So I think that can only get better and more comfortable. Have you had any experience with that?
He was in one of the trials.
Okay.
But that's all.
Do you remember which sensor? Where was he in the trial?
At Children's.
At Children's, okay. Oh yeah, did he come in for a weekend overnight?
No.
No?
Already home.
He did wear it at home, okay.
Yeah.
Okay.
It was a while ago.
Okay.
Do you see many children around the age of 2 that have a pump?
We put them, I'm putting one on a 19-month-old next week, actually.
Because my
So-
son and daughter-in-law
Yeah.
are thinking about
Yeah,
it.
they're
They've
moving
got
in that
appointments
direction.
too.
Yeah.
Are they moving in that direction?
Yeah, we have every diabetes program has protocols for putting children on insulin pumps. There are some prerequisites that they must meet in order to do it. There's some appointments that they must do. They must be awesome at carb counting. There's a minimum number of blood glucose checks that you need to be doing on a regular basis before you even qualify. And then the particular pump that you put on the child is based on the child's size. And we have so many choices now, and there's insulin infusion catheters that we can have them test out.
How do you get it so they can't pull it off? I mean, obviously, you're still supposed to rotate sites. with the
Yeah, you
insertion.
do. Some of these babies, we actually put them on the butt in the back, and it's really amazing that they don't, but they don't. We give our families all an article when they're first interested in this stuff. We give them materials to read, and we give them an article called to pump or not to pump, and it talks about your child's readiness
So they
and
could
what we need to
They
do.
could rotate just from buttock to buttock? or-
Yeah, you can, or leg, sometimes. It's amazing, we find out or arm, we just find out which site works best for the child, and some kiddos couldn't stand it, and so that, that wouldn't be a good fit for them. But we have them wear these catheters home for a couple of days anyway, to find out, first of all, whether they're tolerated, because parents might think it's a good idea, and you go to put one in, and the child is not having it, just not having it. Nor will they wear it, they'll want it off, and they'll cry, and they'll, so that'll tell us whether they're ready. But the age per se doesn't eliminate them. And the pumps keep getting better and better. You can give insulin via a pump in as little as 25 hundredths of a unit. And it's pretty hard to give less than about a half a unit with a syringe. So 25 hundredths of a unit with accuracy is really pretty good. So that's one of the benefits of an insulin pump. And insulin pumps can keep track of all the active insulin that's on board. So with children not on these injections, we say don't give a correction any more frequently than every 3 to 4 hours, because you're going to get these overlapping doses of insulin and then drop them later. But with a pump, you can do it because the pump keeps track of the active insulin, and it will subtract for any insulin that's still active when you need to go to correct them for a high blood sugar. So they're quite sophisticated.
Do you see anybody with the diabetes dog in your
I actually have a little one
Well, they're looking-
that just
they're
got a
looking into that
diabetes
right now.
dog. Interesting, yeah.
Is there someplace in Massachusetts here that?
Yes, I'm trying to think. This family was from the Cape, but I bet if you Googled, did a Google search.
Well, I did see a site, but it was, I didn't see anything with Massachusetts. But
Yeah.
I'll look again, I didn't do it.
This was like a little puppy. He was like adorable, and the family was saying that they're still training him. It's a
Oh, yeah,
process
right.
to get him to alert when the child is low. But a couple of times they did, and the little boy loves this dog and wanted a dog anyway. So they're like, we're going to go for this dog. So, and I think their local Lions group or something helped them pay for it too, which was really nice. So I just have just one. Yeah.
What is the dog? I've seen pictures online. My daughters have friends down in Florida.
Right.
That their children have. And the dog just knows that the child is low?
Well, I think because of their sense of smell. I think.
It's the smell, right?
Yeah, I believe so. I believe that they can, their breath and everything else, and I think that that's how they alert them to it.
Do you think it's because of that child, the danger of that child? I mean, there are different levels of someone being on diabetic, and they're in a dangerous situation, or is it just the youth, the age that makes them a dog be better than a?
No, I don't. Very few of our families have a dog to do this, but it just appealed to this particular family. They wanted a dog anyway, and so they thought they'd give it a go.
The dog zoo, I know when my granddaughter had, the dog would follow her around. He just knew to stay with her.
Interesting.
And barked when something, and the dog would bark when there was something wrong?
My daughter knew that when the dog was following her around,
She better check?
Yeah, he would just stay with her. It's weird, huh? Just a family pet.
Wow.
The dog wasn't specially trained.
No.
Wow.
No. I mean, it could be coincidental for sure, but
Right.
I think dogs are very.
They do
caring.
have senses that we don't have, so. Yeah. How about any other questions? We're going to have to finish up pretty soon. Is there anything else that, let me just look in our list of things that, I'm sorry? Oh, diabetes burnout? Yes. As part of your diabetes team, every diabetes team has support for families. So your diabetes team is your physician, your diabetes educator, your nutritionist, and your social worker. Those are four, very important components of your diabetes team. And sometimes the parents need the emotional support even more than the child. Sometimes the child will totally resist it, especially during the teenage years. And there's a great handout in here on sort of supporting your team, so I would encourage you to read that. But people do get diabetes burnt out, children and families alike. And it's sort of important to recognize that there are so many tasks associated with managing diabetes all the time, especially for your loved ones who really are in the trenches day in and day out. So having you guys really lessens the likelihood of diabetes burnt out because they have family members that are going to encourage them and are going to support them and actually give them respite care, if you will. But it's not an uncommon thing. Has anybody experienced that yet? No?
And sometimes it's just much
Yes. Yeah.
for
Yeah.
everybody.
Exactly. And our teens especially, because don't forget, one of the key developmental tasks of adolescence is independence. And so they want to keep parents at arm's length, and it's impossible to manage diabetes well on your own. So those are key years for families to stay involved, even though the kids are pushing them away. There's some things that we'll say to families all the time about negotiate with your family, and we'll say to the kids, what helps you, what doesn't help you? Well, don't be the diabetes police. Don't everything, what's your sugar, because it seems like that's the only topic of conversation, and kids really do get sick of that. So you have to sort of have when am I going to review blood sugars, and how are we going to negotiate this? But families can often do things like, I've made dinner, this is the carb amount in every single thing here. So you're constantly showing that I'm aware, I know. My family was great. Whenever they made anything, they brought me the recipe. And I could calculate, because you learn what a cup of flour, how many carbs are in a cup of flour, so you can still have your favorite birthday cake. You just have to, just calculate it all. And then if you make it in a sheet cake, it's way easier than a bundt pan, because it's like, what's a 1/12 and a 1/16 of a bundt pan, where it's easier. Sort of, I mean, you learn these, you absolutely learn these things. The other thing is the record keeping, which our teens hate to do. They hate writing down these numbers, hate. And parents often feel that, well, they're getting older, they should do this. But I can tell you that for them just being a normal kid and a normal teen, it's too much. It's really too much. So if you model to them that this is important enough so that I'm going to take the time to support you with this, once they get through the, once they come back from the dark side, when they're teens, they will see that that's very, very important. So I think your grandchildren are in a very good place to have you all here.
I think it's a hard thing for them. I know he's only 5, but he likes to be in charge of things. He likes
Yeah.
to be in
Right.
control.
Right.
So we always let him, like, he picks where he wants, because we're still doing injections, so he gets to pick.
Yeah, where the site
Arm
is,
or
yeah.
leg or
Right,
tummy or
right,
whatever he wants.
right.
And it's both of his parents and me that he gets to pick.
Who gives it?
Who gives it,
Mhm.
and then we get rated.
Oh, that's adorable.
And he'll crack, like, he'll say, oh, man,
Yeah.
you did much better this time. Or funny, I did something wrong.
Yeah,
It's
yeah.
like, okay, I'm trying.
Oh, that
And
is
even his
great.
3-year-old brother, who the other grandmother said she was nervous. She doesn't live near here. She was
Right.
nervous to do it. And I said, if you get confused, just ask Jack, who's the 3-year-old, because he talks, a blue streak, and talks you through everything. Like, he'll say, no, don't forget, you have to use the alcohol wipe before you put the needle in, to do this and do that.
Wow.
Click it 3 times, and, okay.
Wow,
It's amazing.
wow, wow. I'll never forget my son preferring my husband giving him the injections. And I was the medical professional. I was incensed. Daddy's much better. I want Daddy to give it. It was great. It's great, that's right. Yeah. Any other tips that you guys want to offer?
I would just say don't worry about it. It really just becomes part of the family, and you get used to it. Don't you feel?
Yeah, I think it's so overwhelming when you
Yeah,
first,
right
now
you
it's
know,
overwhelming,
it will
but
get
it
better.
will.
It
It
will
does
get
get
better,
better.
really will. It is, I mean, I cried the minute I would
Right.
think that, the first, couple of months even, and I just either see her or think about it, think, oh, how does she?
I thought
that
we'd
was-
never come out of that time.
Yeah.
Yeah,
You know,
right.
I
I
thought
think
life would never get normal
I
again. that
know.
We'd never be able to go out to eat, we'd never be able, he'd never do anything regular, and we came out of it.
Yeah.
But even like yesterday, I picked him up after school, and he'd been low, and they had given him glucose tabs, and so I had to check him again. And then he was sky high, so I said, there's something not right here, let's check you again, which I sometimes do if it's, just doesn't seem right. And he started to scream, I hate diabetes, I hate this, why did this have to happen to me? The whole bit. He's 7.5. And all you can do is agree with him. Yeah.
That's good that
That's right.
But I felt so bad for him, and you don't know whether he's screaming because he's really, really high and there's something wrong, or it's just a normal emotional response. So it's that fine line of they are normal kids, we treat them like they're normal kids, and this is just part of their lives. But this is a big part of their lives. So it's the cart before the horse. I tested him again, he was still high. So, obviously he ate a little bit too much over.
Right.
But sort of what she said, you don't forget it, you don't get over it, but if you just do what you normally do, you manage to get through the day. The first day that I was alone all day with him for some bizarre reason, I decided to take him and his siblings to the Museum of Science all day. And I know it made both his parents very nervous, but I said to my daughter-in-law afterwards, I said, first of all, I picked it because their father worked 5-minute walk from the Museum of Science, and my best friend is my cell phone, my iPhone.
Yeah.
you know, if I have a question or a problem, I text or call them, and I have an insulin calculator in there, and I have multiple carb counter apps in there.
Oh, there's
and all
fabulous
that.
apps out there.
Awesome apps. You
Mhm.
can, and so anytime, you know, if I had a question because he decided, kept convincing me that I should let him have M&Ms, which I kept saying, yes, you can have the M&Ms, but you're gonna need a shot. And then, of course, he decides to have M&Ms at 11 o'clock, so I was confused as to whether that meant now I had to test and cover for a snack and lunch.
Mhm.
So I called my son at work and said, okay, you know, what time are you gonna eat lunch, and do you know what he's gonna have for lunch? And again, to your like putting him on a regimen, we're not technically in a regimen, but we had already discussed nuggets, so he was having nuggets.
Yeah.
And so I just got advice, and there's also like in my phone, I have programs there, Nurse Educator, and all of the people that they call. I mean, everyone's just a push button away, so there's lots of help.
And that must give them comfort that you say, I'm gonna call, I'm not gonna try this by myself.
Right.
I know where I can go for a question, so that's good.
And I'm still going to the Museum of Science.
Yes.
It's a good one, yeah.
It's great.
Yeah.
It's great.
And the baby had the grace to sleep during lunchtime because the cafeteria is crazy. And an 18-month-old and insulin, and a 3-year-old would have overwhelmed me, so I was glad for that.
Wow. Wow. I think that's incredible that you did that.
I do.
Really,
I do too,
really.
yeah.
That's,
I went home and took a nap.
that's amazing.
I would have
Because of you, they went to Disney World.
That's right.
That's right. That's right.
Good for you.
It's a great stories. It's great stories. Any last minute questions or?
Thank you.
Thank you.
Okay.
Yes.
You're very welcome. Thank you. Thank you. And have a wonderful visit with your
Thank you.
grandchild.
Thank you.
Thank you, Ginny, for
Thank you.
sharing, and everyone for sharing their stories. I have some information about JDRF if you want to pick it up. If you have questions about our support programs or resources, and don't hesitate to call anytime. If you want to connect with someone else, you know, I can share email addresses if you guys want to communicate after the fact, but we have a lot of education and support programs that are welcome, you know, for grandparents and other family members, so anytime you're welcome to come. We do our symposium, which is in March every year, and that has a lot of different educational sessions, so you can, you know, always come to those, and anytime you need anything, don't hesitate to reach out.
Spring research briefing is coming up too, which is phenomenal every year.
Posting those videos on our website, so I'll make sure that you receive that information as well as the video today. But yeah, and check out our website, there's lots of good information, reliable information, you know, so.
I
Yeah.
have a jewelry question. It's not gonna cost too much money. You know, everyone has ribbons and for all kinds of
Yes,
diseases.
the causes.
Is there a color for diabetes?
Blue is the JDRF, I think.
Although, you know what,
color.
a mom was in the other day with a Brighton, have you seen the Brighton jewelry, the Brighton?
Yes.
And it was interesting because it was a gray ribbon and it has a little red blood
Right.
drop on it. But I agree, usually it's blue.
Because I've seen gray and purple.
I thought it was a rainbow.
No, I don't think so.
I have
So if you
the-
would-
I mean, like Diabetes Awareness Month, we light up
Yeah.
buildings blue, so I
Yes.
think that's our color of
If you go to
choice.
the walk, it's a rainbow.
But yeah, it's
Right
not like
colors.
breast cancer where we don't have a, you know, a pink ribbon that's
Right,
everywhere.
right. But I've
but
seen a
yeah.
lot of gray online or it's doing.
Yeah, I've
some-
seen the blue and then I've seen the gray with the.
Little
gray
drop on
ruby
it.
or whatever
Yes,
it is.
yeah,
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 so.
yeah,
That's an important
yeah.
question.
Is that for you? For you to wear?
Yes.
Yes, okay. Yeah, because there's all sorts of, excuse me, medical identification jewelry for the kids, which is fabulous, boys and girls. You know,
Oh, I
there's,
went online the first time.
yeah, yeah,
You know,
Yeah.
likes the Disney cars and
Yeah.
some that.
Yeah, we
All right.
have this great one that, it's like a plasticky band.
Yes.
You change so he can wear different colors.
Nice.
Color-coded.
nice. Oh, there's so many. There used to be, you know, Medic Alert was like the big
Right.
one. And now you just Google medical identification jewelry and you can't believe what comes up. Lawrence Hope is a really popular one. LawrenceHope.com. Beautiful things, not inexpensive, but really beautiful. It's the bracelet that Halle Berry wears, and she has type 1, which I wish she talked about a little bit more. I wish she talked about it a little bit more. But anyway, she was like in People magazine years ago, and this little girl's name is Lauren, and her aunt came up with this because she was like, come on, we need to get nicer looking, jewelry than this, and it's really beautiful. So that's one of them, but there's a million of them out there.
What's that
And
called, Lauren?
LaurensHope.com. And then 50/50 Pharmacy does it. 50% of their proceeds go to, diabetes research. And they have a lot of sports ones, that are like the neoprene.
Yeah, that's the one that might.
Yeah, the neoprene is good because, it doesn't get, sweaty. And sometimes the coaches make them take the stuff off. So you need a little clip that you can take them off easy. So there's a bunch of them out there. And sometimes the diabetes educators are good for letting you know about that. But if you go online, they keep adding more every day.
And Halle Berry, that is amazing because she's in her 40s and she's pregnant and she has type 1
I know it.
diabetes.
I know it.
She could speak to so
She could speak to so
many
much,
things.
yeah. Yep, I do have one article on her, and it's in my book, Famous People Touched by Diabetes. And every time my family's, Halle Berry has type 1? Everybody is always amazed. Yeah. Yeah.
Just have a quick question.
Sure.
Is every diabetic child registered so they know these clusters exist?
No, but there's a push to do that. Like I said, Children's Hospital has started to participate in this diabetes registry. Families have to agree to do it, but there is a movement to register for that.
And how does one register? You just,
So there's the T1D exchange, is that what children's?
Yes,
T1D
yes,
exchange?
yes.
I can email that out.
okay.
There's a site.
Great,
That might be
thanks,
very
Lauren.
important. That might be important.
Sure, I think it's really important to know where and number. Okay, great. Nice meeting everyone.
Thank you.
Thank you so much.
Nice meeting everybody.
Yes, thank you.